We'll give them just a few more minutes, but not many. Apple and a banana.
That's a yellow apple.
The yellow apple?
You post the slides.
I don't know. I don't know.
That's a lot of test grades.
What about test grades?
You see those?
Can we see those? You can't, can you? Do you want to see them?
Yeah. Like, do you actually have to go grade them, or do you just open the grades up to us?
I do a statistical review. I really do. And then I move them from one testing platform into Canvas so you can see them.
Oh, yeah. That one, I don't know how I did on that one.
You don't know how you did?
No.
I've been counting the
Actual
lab days.
Okay. I haven't. I was just looking at counting the days that I so yeah, I'll go back and
Got it. Got it. New module has been opened up. We are getting close. I would like to be done with the bulk of lecture by Thanksgiving. That way, when we come back from Thanksgiving, we will have a week or so there. What did we get out? The 9th? Somewhere in the 9th is when we're done.
9th of December, right?
So we won't have much time. But I don't want to be lecturing after we come back from Thanksgiving break.
What will we do instead?
Review. I'm gonna look at the schedules because we are, bless you, well on track and on time. If I have a little bit of time, or we have a little bit of time, I would like to start taking a couple of days and just start reviewing the modules as we go through it. We've got enough tests behind us now to do so. So at break, I'll look at the test and see what the grades look like, to see whether I want to release those. I just got this really weird feeling we may need to retake that exam. The one you just took. We're going to retake all of them anyway, but I don't want you to.
We were kind of shocked when we saw 140 questions.
Were you? I'm sorry.
But that's
It was midterm though. There was a lot of material to cover.
The NREMT is like between 70 and 200, right? Depending on
No, it's not 200. I think it's 70 to 120.
120. Oh, okay.
Yeah. So how was your week?
Pretty good.
Otherwise good? Was your lab day good?
Yeah.
Did Ozzy take care of everything?
I don't think anyone knew who was actually in charge. They kind of just went off in a different.
I sent Ozzy an email directly and said, this is what I want you to do. But it all worked out?
Yes, sir.
Well, I don't guess anyone needs to be in charge. It was a corporate event, right? Everyone, but you got it done.
Yes, sir.
Was it organized?
They were asking us.
Huh?
They asked us to do it.
Yeah.
Ask you what to do?
I don't think they were completely sure.
What did you tell Ozzy to do?
Do you really want me to pull up that email?
Yeah.
Perhaps I should pull up that email to see what we do this Thursday in lab.
Because we did traction splints.
Okay.
Triangle bandages.
Pelvic binders.
Sand splints. How to do a sling.
Yeah. With the
Okay.
ankle bandage.
Okay. So you're on track. You're on track.
Oh, that's for one of your.
I was going to go camping, and then I realized it would not be a good idea because you can't build a fire. Burn bans, man. And I was going to the Pine Woods of Oklahoma, and it probably would not have been a good idea.
They're on right now.
No, you can't get caught.
There's a burn ban right now.
Well, in certain areas, yeah. We're in like D4 drought, which D5 is the highest. But I'm glad we didn't go because my wife and I both woke up like Tuesday morning or Monday morning, scratchy throat, sinuses on fire. I've been battling that ever since. It sounds like some of you have as well. So the air is nasty, dust is everywhere, and fire danger is super, super high. So be careful. My projector's off. I'm not supposed to let you guys see my email, so that's why I turned it off. It's a bad violation. I made it too far to get fired over email now. So thank you for your patience. Thanks for last week. Even though some of it may have been chaotic, it comes with the business and the territory. So we're on chapter 29, head and neck, head and spine. Well, you should have done facial injuries on Tuesday. How was that? Did you get that covered?
Yeah.
And Monday you did trauma systems?
Yes.
Did you do, no you did not, because I'm looking at it. Did you do this on Monday? Okay. All right. With that being said, we will dive off into this. So it sounds like we're in pretty good shape, all considered. So instead of reciting, rehearsing, repeating the same material that you've heard since we started this in August, I like about all the points and the A&P stuff, I'm really going to focus on what does head and neck trauma mean to you as an EMT, and also what's it mean to you on the National Registry, instead of running you into the ground with repeating the same old things. Is there anything on this slide you have not heard before? Anyone? No. I mean, now's the time to review and ask. Is the face and the skull, is the face and the cranium different? Are there facial injuries and then are there head injuries?
Yeah.
What's the difference?
I guess the location.
Okay, that's the obvious. Keen eye for that. What else?
50% of it's in front.
Okay, the percentage of that.
Most of the time you have a head injury, it's going to lead to brain injury.
Head injuries often result in brain injury. Do facial injuries often go along with head injuries though, just because of the locality of it? So if I encounter someone with a severe facial injury, what will I know about that injury? First and foremost, it's going to bleed a lot. And they're hard to contain. They have an airway compromise. So if I see a facial injury, I got to worry about airway. And then I got to worry about blood loss and blood control, bleeding control, because it's hard to put direct pressure on the airway. I can't do that. I can't tie a tourniquet around it. I can't pack a wound there because I'd be packing an airway. So sometimes they're hard to control the bleeding. Secondary to that, the head injury behind it. So depending on the mechanism of injury, do I have what we call a true head injury? And we get those confused because if I say head, it could be face. But for purposes of today's lecture, when I say head, it's brain involvement. So without showing you a slide, the brain sits in a closed vault called the skull. And it's closed after what time period in our development?
It's like 6 months. 8 months.
18.
18, good. So by 18, it should be 18 months, it should be a closed vault. If you got a 4-year-old who still has fontanelles, which are the soft spots, you got a developmental issue. And that goes without saying, right? So somewhere around 18 months, those bones should fuse together. There should be no more soft spots. And now we have a closed vault. So the brain sits in that closed vault, but it's in a sac. Who can tell me the name of the sac that the brain sits in? Actually, the brain and spinal cord sit in this sac. Maybe I do need to flip the slide.
What's a meningeal sac?
Meningeal sac, or what we call the meninges. How many layers are there to the meninges?
Should be 2 or 3.
2 or 3? Should be, yeah, should be 3. And the layer that touches the brain is called the yeah, it's one of the meningeal layers that touches the brain. That one's called the Go ahead, stare it. No, you got that look like, I know. Pia? Pia matter? P-I-A-M-A-T-E-R. And then the next layer out's called the, I know we talked about this, but do you know it? Arachnoid. The arachnoid layer. Why is it called the arachnoid layer? What is an arachnoid?
Spider.
A spider. So it looks like a spider's web. So it's a fibrous, webby looking layer. And then the layer that's out against the skull is called the duramater. Latin for tough mother. So it's a very tough, fibrous layer. And you can remember that because it pads, P-A-D, pads the brain from the inside out. And it does kind of pad the brain. So what's inside the meningeal layers? Anything? There are blood vessels. What else?
There's spinal fluid.
What kind of fluid, Chas?
Is it spinal fluid?
Cerebral spinal fluid. Cerebral spinal fluid. And we have to say cerebral because it's around the brain, spinal because it's around the spine. But please remember that's one fault. It looks like a blob with a tail. And that sac, that meningeal sac, encloses the brain and spinal cord. It cushions, protects, provides nutrients, carries away waste, things like that. Can anyone tell me what the cerebral spinal fluid looks like if I was to get a sample of it?
Yellowish.
It's clear, but it's got a yellow tinge to it. If it's green, if it's pussy looking, green, it could be a sign of meningitis, but meningitis, let's leave that term as just inflammation of the meningeal layer, but one of the causes of that inflammation is infection. What if it's red, got blood in it?
That might be a wound inside that area.
Yeah, then one of those vessels he spoke of is ruptured and we got to bleed there as well. What can we learn by tapping into that meningeal layer? That's a word that they do in the hospital. They call it a spinal tap. What can we learn? What can the physicians and the medical team learn from a spinal tap? In other words, they go in between your vertebrae down here in your lower back and they get a sample of that spinal fluid. I never have enjoyed watching those. They're like, oh shit. You're just sticking a needle in that dude's back, like in the spinal cord area, man. You
Check for meningitis.
could check for meningitis. How?
Check the spinal fluid.
Yeah, but how do we know that it's itis? How do we know that it's swollen? Well, that's the appearance of it, so we can kind of tell infection versus blood. But how do we know that it's the itis? It's the pressure. So we have cerebral spinal fluid, an increase in the pressure. Usually tells me that I have an increase in ICP. For purposes of today, we'll go with that. So there's another abbreviation. ICP is what, Christian? Intracranial pressure. Do we need some intracranial pressure? The answer is yes. What happens when I get too much of it? When ICP starts to go up, what's happening? Increase in ICP leads to well, swelling of the brain could lead to ICP.
Well, I mean, it's a sealed bowl, so something's gonna happen. Put more pressure.
Would it be decreased blood flow because of the pressure?
All of you are right. There's all these ideas. There's word clouds popping up over your heads. All of you are right. Good to start back here. What'd you say?
It's gonna affect the brain.
Okay, it's affecting the brain. You said it's a closed vault. Something's got to give. You said decreased blood flow. An increase in ICP could, I'll put a question mark here, a decrease in what we call cerebral perfusion pressure. So the correct term for what you're stating is cerebral perfusion pressure. That's the blood flow to the brain. And for the brain to work normally, this has to stay higher than this. Does that make sense to you? In order for cerebral perfusion pressure to be good, it has to be better than the pressure that's in the vault already. So what's pushing the blood into the vault? Jordan, you can say heart. The heart's pushing the blood up there, isn't it? That left ventricle. And we measure the pressure exerted on the arterial walls, don't we? During systole versus diastole, we call that blood pressure.
So what causes the rise in ICP?
Hang on, we'll get there. Let's finish our equation though, and then we'll talk about that. So we've got systolic pressure, ventricle contraction, pushing blood through the aorta. It goes up through the carotid arteries and then goes up into the cerebral arteries, and that bathes the brain in its new blood, and then it drains back through the jugular veins, right? If I take the systolic blood pressure and the diastolic blood pressure and I run those two numbers through a formula, I end up with a new pressure that's often seen on heart monitors called the mean arterial pressure, or MAP. Mean arterial pressure. There's a formula to calculate that. I won't bore you with the formula. It's really not necessary for us to know it, because if you've got a heart monitor on someone and you hit NIBP, if you push the blood pressure button on the heart monitor, it'll give you a blood pressure reading like you're accustomed to, 120/80, and it'll also give you a MAP reading. So really, you need to start thinking about it from today forward, all through your EMS career, schooling, and everything else. Blood pressure in terms of MAP. You're still going to hear blood pressures. I want you to start really thinking about that as a MAP pressure. MAP stands for mean, average, M-E-A-N, not a hateful MAP, but an average arterial pressure, mean arterial pressure. What's the average pressure on the arteries? MAP gives me cerebral perfusion pressure as long as ICP doesn't become greater than the cerebral perfusion pressure. So somebody said, well, what causes an increase in ICP? Well, for today's lecture, it's trauma. For today's lecture, it's trauma. It is a bleed in those vessels inside the cranial vault, causing blood to fill the cranial vault. More blood, less space, more pressure. More pressure, more blood pressure to overcome the pressure. We're playing this game of catch up. Like, you do well, I'll do better. You do well, I'll do even better. At one point, you're going to lose the game. And unless there's medical intervention, this game can be lost. Trauma is what we're talking about today. There are other reasons. And one of them is the infectious agent meningitis. When you get an infection in there and the meningeal layer starts to swell, that's also taking away pressure or taking away valuable real estate. We have no room to give. You might argue that some of us have more room to give than others, but we're pretty much full up here, okay? There's no room to give. I need you to understand the seesaw that's going on at any one time in a head injured patient. I need you to understand the seesaw that's going on there. That seesaw is, you get free blood in the brain, you got swelling, your ICP's going up, therefore your MAP has to go up in order to maintain CPP. If you could measure the numbers, you need about 10 to 15 millimeters of mercury CPP in order for the brain to still function. So, how that looks. MAP minus ICP should equal some number greater than 10. Can you understand that equation? Riley? That makes sense to you? So if the body tries to keep this at 10, this goes up, it's going to do what? Turn up the blood pressure.
So if it goes above 10, are they dead?
No, it's just that's the least you can run on. It's kind of like gas in your tank. I don't want to go below a quarter because it gets kind of treacherous, but if I've got more, it's okay.
So in a healthy person, it won't change.
Well, in a healthy person, it's still 10 to 15. Our body regulates that. Just give me a gut reaction. Just give me your first gut reaction when I say this. Trauma patient blood pressure. Crap, down, no good, low, hypotensive. Does that ring a bell with you? Does that inherently just come out of your mouth? Trauma victim, blood loss. Trauma victim, pressure goes down. Now we already know that if it's down, we're in the later stages of shock. But trauma victims, just by rule, should not have a high blood pressure, should they? I mean, I wouldn't think so, would you? You just slammed into a bridge abutment, and you cracked you slammed your skull into the windshield, aka concrete, because they were all right there together, and somebody takes the blood pressure and it's high. Is that like, I didn't expect that. That's not what I would expect here. Or maybe I should change the scenario. Somebody standing on the pitcher's mound takes a line drive from a major league hitter, gets hit in the head with the baseball, calls 911, we get there, you take the blood pressure and it's high. Mechanism of injury indicates head injury, and you've got a high blood pressure. Do you now know why you have a high blood pressure? ICP. You can't in the field. They can in the ICU, but you can't in the field. But I can sure understand the equation and know that if I've got a high blood pressure, then I probably have high ICP. If an EMT was capable, and you're not, paramedics are capable, do I want to lower that blood pressure? So I've got a high blood pressure in a victim that took a line drive baseball to the head. Do I want to lower that blood pressure as a paramedic?
No, because at some point it's going to drop.
You want your maps to be higher, or you want your blood pressure to be, shit, I can't remember which one it is. You want your ICP.
Well, this is a critical thinking question, and this is what you don't get by reading the textbook. It's just, let's just say it's hypertensive. Let's say it's 160 over 110. The next time it's 170 over 130.
It's compensating. So if you lower it, couldn't it cause like brain damage or something?
Why?
Because you're also low.
Because something's not getting enough blood.
The equation's got to hold, guys. The equation's got to hold. So I pulled out this magical drug out of my paramedic box of lethal weapons.
Well, what's the map on the 160 over?
Well, we could calculate it, but we know if the blood pressure is going up, so is the map. And I start lowering this with, let's say, a beta blocker. I got a beta blocker in the ambulance. I got an Olal drug. I got labetalol, and I can certainly lower the blood pressure. What's going to happen to the math? I'm not lowering this with labetalol, but I'm lowering this to this greater than 10.
It'll go down.
I'm not going to be greater than 10. I'm going to be less than 10. And this less than 10 is this magical number over here, right? This is the pressure in the brain, the blood pressure in the brain. So if I drop this, not change this, then this goes down. Now the brain's not getting fed its nutrients. So the answer is, I don't want to lower it by medical means. I want to lower it by, let's get this down. Let's get this number down. This number will follow. Well, you're an EMT. Do you cut holes in the skull to let pressure off? Nope. You're a paramedic. Do I cut holes in the skull to let pressure off? Nope. Now, there is historical archaeological evidence that some shaman in a cave did, and it worked. There are fossilized records of human skulls where holes have been created in their head, and they can tell by the evidence that the hole has healed. You know, this was the guy who was chasing the ginormous piece of dinner off the cliff, and he fell off the cliff with it, hit his head. Now he got, you know, he got infected with the bad gods, didn't he? He got the demons. All right? Because he's acting crazy. And so the medicine man in the religious ceremony said, ha ha ha, we're going to drill a hole in your head and let the demons out. And the guy got better. Must have been the demons. It must have been the demons, right? I think one day they're going to look back on our medicine that we do today. He's like, can you believe what they did? Kind of like Star Trek, you know. Look what these savages used to do to people. Let the demons out. What were they letting out? Letting pressure off, weren't they? And there's evidence that these people lived and recovered. Now they had a permanent soft spot. So today we just do the same thing, only we either preserve that piece of bone in a preserving solution, or we'll put a steel plate back in its place. You've heard of people with steel plates in their head? We'll put that back in your place. But that's how the neurologist, the surgical team, is going to relieve that pressure, is they're going to open up the damn skull. So in some ways, an open head injury is better than a closed head injury. So let's talk about those two terms for a moment. Open, closed. At face value, which one's better?
Well, depends.
Okay, yeah. Nothing's that absolute in this business, is it? Don't y'all get tired of depends, maybe? I think they sell underwear for old people called that. Depends and maybe. I would invent a new one called maybe. Wear this because maybe it will happen to you. Yeah, maybe. As far as ICP, open head injuries don't have that effect. Open head injuries don't succumb to the effects of that. As a matter of fact, open head injuries, this gets too low sometimes. And the body doesn't know what the hell to do with that. Give me another open head injury disadvantage. Blood loss. Huh?
It's hard to see.
Hard to seal. Definitely hard to splint.
Cerebral spinal fluid in there?
Okay, I could leak out that precious cerebral spinal fluid. I could leak out brain contents. I've got an open wound. I'm open to infection. I could have contents spilling out. I know I keep referring to the Hank Williams story, but that's a good story. Fell off Ajax Mountain, cracked his head open. Brain content was exposed to the atmosphere. But he did not die, and he did not succumb to the effects of an increase in ICP. His biggest risk was make sure all the brain comes with you when we leave the scene, and infection risk and blood loss and stuff. Those injuries bleed to death or contaminate, secondary. Closed head injury won't bleed to death. That's a key point. So that's a ding ding right there. A closed head injury will not bleed to death. One more time. A closed head injury will not bleed to death. So if I've got mechanism of injury that indicates a closed head injury, how do I know if it's closed? Riley, I'm touching you. I didn't even ask, but I'm telling. How do I know that it's closed?
You palpate it.
I palpate it and it seems to be intact, doesn't it? Oh, that was soft. It's no longer a closed one. I just found it to be open and I stopped sticking my finger in that. I'm reading this book I was telling you about, and this guy got his head crushed, and the paramedic was pushing, palpating, looking for DCAT BTLS, right? And as he was doing that, the firefighter over him said, every time you do that, his eyes blink. He's like, well, I thought his eyes were closed. And they're like, no, they blink when you press there. And he's like, perhaps you shouldn't press there. Perhaps you should stop that. Yeah, that's, Look what I can do. No, creepy. A closed head injury will not bleed to death. So if I'm palpating someone with a mechanism of injury and I check up blood pressure and it's in the tank, in other words, it's low, it's hypotensive, it's decompensating, what do I have along with this? If I've got a closed head injury
Increase ICP.
and I have a no blood pressure, if my blood pressure is going down,
You have brain damage. You have no perfusion. No circulation.
right, but what else do I have? Yes, you do have a dead patient. What?
Internal bleeding.
Yeah, I got bleeding somewhere else. So if I'm doing an assessment on someone and the mechanism of injury is, man, look at their head injury, but it's closed, I don't see any blood on the ground, and the blood pressure is down, he's 100% right. I've got a secondary internal bleed going on somewhere. And you're 100% right. Give you the final acronym here.
Couldn't they still be breathing and be dead?
Mm-hmm. These are these people that are dead and nothing's caught up with death yet. Death has outran them. Like, I'll wait on you up here, but come on, you're dead. Another way to look at this. Low MAP with high ICP equals to RIP. Now that's not in your textbook either. But if my MAP's in the tank and my ICP's up, this guy's gonna die. If he doesn't die from the shock, just the pure out hypovolemic blood loss shock, he's going to be at least brain dead from the no perfusion to the brain now. One more time, you cannot bleed to death from an isolated closed head injury. So if it looks like they're bleeding to death, but you don't see the blood, Frank's 100% correct. It's somewhere. It's somewhere. This is a challenging trauma patient. Is it, question, multi-system trauma? Is it, or what level of trauma center does that patient go to? Kind of review your Monday lecture. What level trauma center in the state of Texas does that patient go to? 1. Because it's multi-system and
He's about to die.
about to die, and what other specialty needs to be involved here outside of orthopedic or chest trauma? Neurology. And you don't find neurologists at level 4s. You can find them at 3s and 2s, but when you need a neurologist, an orthopedic surgeon, and a thoracic surgeon all working on you at the same time, they're working on your bone, they're working on your chest, and they're working on your brain. That's a team that's probably found at a level 1. That's a Parkland scenario or a Medical Center Plano scenario, right? Is this an easy mechanism of injury to find? In other words, is this a commonplace in our everyday life to get a head injury and a chest injury at the same time? Really? Luke tests it every damn day. Sorry, Luke. You just happen to be a good candidate, and the truth hurts, my man. If it hurts, I don't know. It will one day. And it won't be you, Luke. It'll be some old grandma who pulls out in a 1948 Buick, gonna go get her Walmart order. And you're gonna cram the side of that Buick. It's gonna be chest trauma and head trauma. It's an easy mechanism of injury. It's out there. Sorry, Luke. I hope I'm not prophetic on that. But it's easy to find, guys. It's easy to find. What about a bar fight? Somebody gets stabbed and goes down and gets their head kicked by some cowboy. The blood pressure should be up if it's a head injury, but if it's down with a head injury, I've really got something to worry about there. Those are high acuity patients. They need to leave the scene quickly. This is when you make that clinical judgment in the first 2 or 3 minutes on scene, if not sooner. This guy's got to go now. This guy's got to go now. I've been stating like worst case scenarios. Frank, would you agree with me? There are probably lesser case scenarios that kind of like come on over the course of minutes, hours, days. There are, and we should talk about those. Any questions so far?
What should be up with injury? You just said that something should be up with injury, and if it's down, they have to go.
Yeah, blood pressure. If it's an isolated head injury, I expect the blood pressure to trend upward, not downward. If it trends downward, then I've got a secondary injury. Now, Amber, I use the Luke scenario because those are sudden. I use the bar fight because those are sudden. We need to now kind of take a breath and look at Grandpa, who slipped in the shower this morning. The mechanism of injury is not very big. It's not sexy. It's not romantic. It's not a mass casualty, plant explosion, tractor rollover, motorcycle wreck, 75 miles an hour to a bridge abutment. Y'all remember Paul Harvey? I know Regan does. Paul Harvey. The rest of the story. Regan, how's that make you feel? How's that make us feel?
I really like the guy.
If you don't know who he is, go to YouTube and listen to some Paul Harvey rest of the story. Paul Harvey was a commentator. He was a news guy. He came on the news, like the news would do it, and then he'd close with some Paul Harvey. It was a 2 or 3 minute little story. And it was always a wisdom-filled, educational, upbeat, good story. And he's so much an orator. He could speak so well. And he just had a calming voice. Paul Harvey talked about a guy who found, those of you guys in the military know what this is. You know when these heavy cargo planes have to take off on a really super short runway and they strap the rocket assisted things to the wings to help them take off in short distances to provide an additional, I think it's 10,000 pounds of thrust per little rocket. Don't know what I'm talking about? No. What are they called?
Jet assisted takeoff.
Yes. I knew there was a military acronym for it. So they would put them on these heavy cargo planes to assist their lift, to give more thrust to get off these really short runways. Well, this Yahoo found one somewhere. Some Yahoo found one somewhere that was still intact, has not been charged or discharged. He strapped it to the top of his car and lit it on the highway. Bystanders stated that the last they saw of the car, the tires had came off the car and it was rolling on the rims with sparks flying off the rims before it slammed into the bridge abutment. There was no evidence of the car left. Now that's trauma.
Did you see the flat earther the other day? He strapped himself to a rocket. He was 64 years old. It's all on video.
That's a trauma.
Well, he just goes up and then the rocket turns. Straight into
That's a trauma. Skydiving Dallas. They get about 1 or 2 a year, don't they? You know, I don't mean them out there, but if you're going to go jump out of a plane, there is a high risk that you will die. Probably a lot less, though, than getting in your car and coming here this morning. It's probably safer to jump out of that plane than it is to come here. Probably. But it seems like there's one out there all the time. Those are quick. Contrast that to the one that takes a week. And we have those. We have the grandpa who slipped in the shower. He doesn't want any help. He slipped, he hit his head. He's got a little cut right here on the forehead. It's really hard to control because he's on Plavix or Eliquis or something. But his lovely little wife holds a towel there and finally gets the bleeding to stop. She calls 911. He doesn't want her to because he's stubborn. I don't need anyone. I'm fine. So they walk up. She goes ahead and calls, and you get there, and you've got to deal with this guy. His blood pressure, you don't know. You don't know what's good or bad for him. Does he have a history of hypertension? Sure. Does that just skew your assessment immediately? I mean, what's a good blood pressure for him now? What's his normal blood pressure? He only takes it when he goes to the doctor. But he's got a history of it. Do you expect it? So if you took it and it was 132 over 96, you're 70-something years old and you got a history of high blood pressure? I mean, that's pretty good, isn't it, Grandpa? That's pretty good for me. Your assessment is so jacked up, isn't it? Is it not jacked up? Well, what was your biggest problem with this assessment so far? What's your biggest problem with this assessment so far as I've stated it? Because you just admitted to me it's messed up. You're like, he's got a history of high blood pressure. It doesn't look that bad. And he says, that's pretty good for me. What's the problem here?
Might be low.
Might be lower than normal, might be higher than normal. You know there's an issue with blood pressure before this even started. The problem is you're looking at blood pressure, aren't you? That's the problem with this assessment. Yeah, we didn't look at that, did we? We looked at his blood pressure. We got a number. I did something. Remember, I keep harping on that. Don't know what else to do. Let me take a blood pressure. Now I got something. And you anchor. It's called anchoring heuristics. And heuristics goes along with the Greek word eureka, as I found it. And so if you anchor around that one piece of information and try to base everything off of that, you started at the wrong gate. You're not running the right horse race. The horses are going that way. You went that way. Why? Because you picked up the wrong piece of information and tried to build off of it. I went to EMT school and all we talked about was MAP and blood pressure and head injury, so I know I got something going on here. And Jonah, I think we need to go back to that. Just don't worry about this yet. How do they present? Now, our jet takeoff assisted cartilages on top of a Buick, or slamming the motorcycle into a Buick, or falling from the sky, all of those present with, oh hell, when you get there, right? The presentation is, that's bad.
They're more than likely going to be unconscious.
Yeah, that presentation is, that's bad. We got to go back to Grandpa though, because here's the point. Grandpa, over a course of a week, Luke, people like Luke who ride motorcycles and crash over the course of a few seconds. I'm really trying to get him off that bike because I like Luke and I don't want to see him injured. And I know he's a good rider, but there's a lot of bad drivers. The point is they both die. The point is they both end up death. The point is we got time with the 1 week grandpa that we didn't have with the other. It happened so fast we couldn't intervene. Grandpa, we need to be very aware of the subtle changes for correct intervention. Because if I just tell, well, you know, Grandpa's stubborn. He said, I don't want to go. Didn't want you here to begin with. I appeased her and let him call you. Just let them come check you out, honey. And if they think it's okay, I'll be satisfied. And he said, if it'll shut you up, get them here. So you go out there, you look at his blood pressure, it's 136/92. And he says, that's pretty good for me. And you're like, that's pretty good for him. Okay, sure. Hey, you got that little cut on your head? Yeah, I know. Well, it's not bleeding anymore. As a matter of fact, that cut can be covered with a large Band-Aid. Do you want to go to the hospital? I can hear the paramedics and EMTs saying, do you really want to go to the hospital? No, I don't want to go to the hospital. Shit, are you kidding me? I want to go eat breakfast and go start my day. I got leaves to rake. Hey, what do you think? Well, if you don't want to go. Sir, we can't make you go against your will. You're A&O times 3. Do you know who get in that big fight? And you're like, no, man, he's good. You can still smell the cheeseburgers on the grill when you left, or the bacon's still cooking. Maybe it's the morning time. You can still smell the bacon in the fire station or the EMS station as you left. And your stomach was already growling because you didn't eat. And you're like, oh, I need to get back and help them clean up. And you know, we're supposed to be at that standby event at 10 o'clock. And we need to eat before we go. Or hey, my sexy little nurse friend was supposed to drop off some breakfast for me at the station. We need to get back. Do you see all these things pulling at you? You can't let that happen. That's just irresponsible, but it happens. But you got an old man here saying, I don't want to go. I want you can I just go about my day? And you're like, sure. Sign here. Now, you know you can call us if you ever need to. And we'll gladly come back. He's not going to come back. He's already worked. You're going to charge him for that. He's not going to call you again. But he doesn't wake up from his afternoon nap. Or he goes to bed tonight and he doesn't wake up in the morning because he has a slow bleed. He has a slow bleed. Slow bleeds are hard to find. And I'm just going to call them a slow bleed. Most slow bleeds are subdural bleeds. Subdural. Under the dura. Remember that layer of the meninges? Subdural, slow. Usually venous. Subdural, slow. Usually venous. He's got this slow subdural bleed. And it's somewhat tamponaded because it's in the vault, but still it's oozing out. And so he may go on and rake his leaves. And then he comes back in for lunch or a mid-afternoon nap and he tells his wife, he's like, you got any Tylenol or Motrin or something? He said, I got a little headache. Do you expect to have a headache after you hit your head? I mean, you can see old people going, yeah, you probably, let me go take some Tylenol. I told you should have just went in and had them check you out at the hospital. Honey, we've already been through this. Give me 2 Tylenol. What's the blood doing? Slowly creeping into the cranial vault. It's slowly displacing, and I got a slow increase in ICP. So what's that look like? You tell me. I think you know enough now to know this. What's this look like? How does it present? What are your findings? What are your assessment findings?
You could find bruising depending on how many days you're looking at.
I like them both. They're both correct. I see some bruising, and that's time. And I'm glad you mentioned time because bruising takes time. If I go and I do my little assessment and I find some bruising over the mastoid bone, mastoid process, and that's behind the ear. That's subaurical hematoma or ecchymosis. Auricle is the outer portion of your ear, sub under it, behind it, ecchymosis, bruising. That's very late, Sterrett. That didn't happen while I was coming out here. That didn't happen 5 minutes before the dispatch call. That happened 2 or 3 days ago. That's a very late finding. So bruising, okay, could be late. Bruising is usually a late finding. Somebody said he appears intoxicated. I'm just going to abbreviate that, altered LOC. Altered level of consciousness. Yeah, they appear intoxicated. That damn collar caught the hair on my neck. That hurt. They appear intoxicated.
Swelling,
Swelling where?
maybe in one certain spot. Maybe he has a big lump on his head where he hit it.
Okay, what do we call those? What do we call those blood-filled tumors? Yeah, I heard it out there. Hematoma. Now I'm going to put a big question mark beside hematoma. This is probably something your grandmother told you at one time when you were a kid and you fell and hit your head and you got this big knot on the side of your head. And she probably said, well, I heard that if it's swelling on the outside, it means it's not swelling on the inside. Anybody ever heard that one? No? No one's heard that? You never heard that, Chaz? Well, don't believe it if you hear it, okay? Just because it's swelling out here does not mean it's not swelling in there. It could very well be swelling in there. And what I want to take from that is, I want you to take from it, that's not in the cranial vault. So this hematoma on the side of the head is not putting pressure on the brain. However, if the mechanism of injury was enough to make this bleed and swell, could it bleed and swell internally? The answer is yes. So it's evidence that the trauma was significant enough to cause some bleeding out here, could have that hematoma going on the inside as well. What else? Death. I love that one. Yeah. That's probably down here, but yeah, that's there. Altered level of consciousness. What about a decreasing level of consciousness?
Respiratory failure.
Hard to arouse. Have you heard this one? And if you haven't heard this one, I don't know where you've been. I may go ahead and retire today if you haven't heard this one. I might just leave you stranded. Have you heard this? He hit his head. Don't let him go to sleep.
Someone said that before.
Not allowing someone to go to sleep has no effect on intracranial pressure. Let me assure you of this. If it gets bad enough, they will go to sleep no matter how much coffee or stimulation you try to provide for them, okay? You know where that comes from? Grandma, yeah. Do you remember the demons that came out of the caveman's skull and he lived? So what must have been the problem? The demons. if somebody takes a blow to the head and they go to sleep and they don't wake up, what causes their death? Going to sleep. So if we don't let them go to sleep, they won't die. Keeping a head injured patient awake is not going to reduce the trauma. Does that make sense? Now, there may be a secondary reason. If you're asleep, I can't monitor your LOC. We get that, right? That's called observation. And we've messed that up. We've messed that up, and Grandma's messed that up, and somebody's heard that, and we've made that assessment finding really terrible. I think the point is we need to observe their LOC over a minute at a time. It is now decreasing. So where do I get that baseline information, Luke? I mean, I'm here now. How do I know if they have a decreasing LOC? Because what I see is what I get. How do I know what it was? I wasn't here 5 minutes ago, an hour ago, last night. How do I get that information? Bystanders, wife, spouse, somebody's been close with them.
Common sense, maybe? If he was driving a car by himself?
Common sense to the point to where he certainly altered. He probably wasn't altered yesterday when he drove the car or was climbing the ladder or shingling the roof or whatever he was doing. This LOC is altered enough, I don't think this would be his daily norm. Very, very, very subtle signs sometimes. And sometimes these are so slow that they take days to show up. My dentist died last year before, probably a year before. Time gets away from you. He's a dentist. He's educated, great man, older man. I went to him when I was 8, and I went to him when I was 54. I mean, he's been doing dentistry a long time. But he still looked like he was in shape. He was still fit. He was semi-retired. He raised cows out on a ranch north of Caddo, Oklahoma. He was just living out his better days. He was hanging a picture and missed the rung coming off his little step stool, fell and hit his head. Went to bed, and that was it. His wife found him stiff and cold in bed. What happened to him? He had a head bleed. He had a head bleed. But he just went to bed. And yet, and he's an educated man. And I'm sure a dentist, he knows anatomy, especially of the head. I mean, and he's on a blood thinner, and he knows the side effects of that blood thinner, but he didn't think it was that big a deal. So what do we do with all these patients now that are on any form of anticoagulant medication, aka blood thinners? We take them. We insist. We insist. And we have to tell the story. We have to let them know that this is an issue. So as time goes on, things tend to go bad to worse. It could be it's decreased so much that now they're unconscious. Their AVPU, remember AVPU? Alert, verbal, painful, unresponsive. They're progressing down the AVPU scale. And depending on the rate of that progression is a great indicator of the rate of bleed.
So as us, when it comes to this stuff, obviously we can't fix that. Main thing is to stop the bleed, respiratory, right?
Yeah, we can't. We'll get into treatment in a minute, but yeah, you're looking at it, I think from right now, your vantage point is, I'm pretty limited here. Go back to this a minute. If this is going up, what does this have to do? Is there a chance Grandpa's on something that keeps that from going up?
Yeah.
So not only is he on the blood thinner, which makes the bleed come about easier, he's also on a medication that keeps him from raising his blood pressure.
Like what?
Like a blood pressure pill. like a beta blocker, like a lisinopril. Stop and think about this a moment, and then I'll give you a break. Stop and think about this. There's more thought in this chapter than there is raw information. Based on what you know from your medical lecture, one you just took a test over, based on what you know from medicine and drugs and pharmacology, and I made you do the top 10 prescription list. There was a reason for that. Now I want you to look at that and refer back to your list. If someone was on a blood thinner, what else were they also on?
Blood pressure.
Blood pressure medicines. Who was it? I think, Amber, it was you this morning when Dean and I were in here talking. Sometimes we're running from the four horsemen, but the medical system is tripping us. Once you go on those blood thinners and blood pressure medications, you should probably do what? Nothing. Which will probably put you in your grave even earlier because now you're sedentary. I know a lot of older people says, I can't be doing that anymore. You know, I take that blood thinner and I may cut myself. And if one of these old men or women have ever cut themselves, and the process to get that bleed to stop may even require hospital admission, boy, they are very reluctant to do anything again. You know, they're just not going to risk any activity. The point of that is we go in somewhere in that mechanism and interject, Jonah, and that's what you're wanting to do. You're like, I want to help. I'm here. I'm supposed to be here. You called me here. I'm under legal obligation to be here because I have a duty to act. You're paying me to be here. What am I going to do with you? And we'll start talking about that after break. Before we go on break, though, any questions about the topics? It's kind of deep. I mean, there's a lot happening here. A lot more than what you see up there. Luke, you kind of see what the predicament is? Frank, you kind of see what's going on? What? One question. Please, let me have this one more question. I'll put my marker down. And you know, if you ever get a man to talk, just give him something to play with. If you're ever under interrogation as a male, do not pick up the stuff on the table that's offered to you. There will always be trinkets, fidget toys. Sit on your hands if you want to keep your mouth shut. What does this look like? Referencing last 8 weeks. Referencing your medical chapter. What does this look like? Unclear? Thanks.
I'm saying, like, how do we know for sure?
Oh, okay, yeah. But what else does it look like? What medical condition does this look like? From stroke. What's the only difference? Trauma or not trauma? Mechanism of injury or nature of illness. Yeah, so there's nothing new in this, is there, necessarily? One's just got a medical cause and one has got a trauma cause.
So what if the trauma causes both? So what if they get to the point of pressure to where it does?
Then TMC is going to go, does trauma get this or does medical get this? Does neuro get this or does the trauma surgeon get this? And it may all go back to your assessment.
So
I mean, if he stroked out driving down the road and now got a secondary, can you have a clot and a bleed?
Yeah.
Can they give you something for the clot to bust up the clot if at the same time you have a bleed? No. The horseman got you. If you're young and healthy, all horsemen are running at the same rate. But man, it's kind of like the game of Uno. Every now and then you're going to get dealt a card that one horseman's just going to get right there on your butt. That's like immediately. And that's called accidents and bad luck, and you drew the wrong Uno card. And the best you can do is get so far ahead of them That's called resiliency. And we don't have much resiliency in the population that we're going to serve. Okay? All right. You're promised to break.